Thanks for that introduction and the invitation. It's a real pleasure to be here. What Tom didn't tell you is that I know absolutely nothing about dental care. And so I'm hoping that the comments that I have to make will at least spur you to imagine and extrapolate to things that may be useful in the course of doing research on dental problems. It's a little intimidating to be here. After listening to Tim DeRuin, I feel like I'm bringing coals to Newcastle, and I suspect I could learn something from you guys about how to do PBRN research. So let me just start off with a few basic concepts here. See if we've got the right slides. Good. So what I'll do is try to talk a little bit, as you've already heard, about what's unique about practice-based research. I'll talk a little bit about why I think it's so important and what the need is. And then I will show you some examples of influential research that's gone on in medical PBRNs and talk a little bit about future possibilities. So what's unique about what you do? First of all, I think that it really helps to guide all of us towards more evidence-based practice. And my simple-minded definition of evidence-based approach is that it's not enough to know if a treatment ought to work. We've made that mistake in medicine many times. Or it makes physiologic sense, or it's common practice, or we learned it in medical or dental school, or we've always done it that way, or an expert vouches for it, or it works in mice. Those have all been reasons we did things in the past, and sometimes those things turned out to be ill-advised. So the evidence-based approach asks, what really is the best evidence that a new approach will extend life in medical practice or improve quality of life, and what are the risks? Simple enough notion, and yet that's not always the way that we've practiced. So evidence-based practice, I think, really requires more practice-based evidence, which is very different from the type of discovery research that typically goes on in academic medical centers. So academic medical centers are trying to find the cure for multiple sclerosis or the cure for cancer. That's not likely to come from practice-based research networks, but what we will learn is how to help make sure that once those treatments are discovered, they actually get appropriately used and appropriately disseminated, and that they actually improve the quality of care. So a different set of topics entirely, different patient populations. Practice-based networks are seeing average patients all the time, folks that have routine, often mundane problems that are very common. Academic medical centers see really weird things, patients that are truly tertiary referrals. They've been referred and referred again, and they often have the weirdest of things, and that's often how we train our junior physicians, and yet the patient population out in practice is often very different. Pragmatic intervention studies as opposed to extremely fastidious trials, and we'll expand a little bit on the difference between those two styles of clinical research. Improving the delivery of effective care. Believe it or not, there's a lot of effective medical care that never gets delivered. And I think the potential for PBRNs to really help us create more relevant guidelines that aren't just coming from the Ivory Tower and that are sometimes misguided for average practices. So you heard Dr. DiNucci talk about the new paradigm of translational research. And here's what I would sort of describe as the traditional view of translational research. You start back here with some laboratory or basic science research that's going on. This is molecular biology. This is stuff that's happening in a laboratory, often involves animal research. And people have recognized that there's often a real challenge in going from those kinds of discoveries into actual human studies and doing human research. So that's a translational step that often creates a bottleneck. Then we have clinical research of various types, perhaps epitomized by randomized trials. But then there's another translational step that creates a bottleneck, and that is once we've demonstrated that things work pretty well in randomized trials, it's sometimes a challenge to actually make sure that the right care gets delivered to the right patient at the right time in routine practice. And that translational step happens in a fairly haphazard way, if you think about it. In medicine, it happens with a little bit of continuing education, and of course you may or may not choose to go to the particular continuing education course that's highly relevant to your practice. It depends in part on drug and device representatives who often are not giving us unbiased information about new practice patterns. It sometimes depends on impractical guidelines that have come from the Ivory Tower and that just really don't fit our practices very well. So it's often a funny haphazard process, and I think it's this step really is where PBRNs have an important contribution to make. So people have reframed this instead of having these two translational steps to thinking about this first translational step as I've described it, then a second translational step that might actually be from these randomized trials or from sort of fastidious clinical research into practice-based research, where we might be doing randomized trials, might be doing post-marketing surveillance studies of new devices or treatment approaches. Observational studies might be testing new strategies for implementing care, such as case management strategies, team care, decision support approaches that might make use of electronic record information, patient education approaches that would be novel, and I'll expand a little bit on all of those. But that in turn then facilitates this step and makes much more systematic this step from bedside or clinical research into genuine practice. And as Dr. DiNucci noted, what happens then is that these arrows are really bidirectional. You out there in practice can identify new important clinical questions and gaps in care that in turn feed back through this whole process and certainly should influence the nature of the research process itself. The other thing that of course is obviously different about practice-based research is just the ecology in which you practice. This is a picture that comes from what's actually an old article in the New England Journal of Medicine. This 2001 article was an update of one that was decades earlier that pointed out that if you start with 1,000 people in the community, in a given year, maybe 800 of them are going to have some kind of symptoms, but only 300 of them might consider seeking medical care of some sort, and 200 of them actually do go to see a doctor. About half of those in our country, 100 of those maybe are seeing a primary care doc. Some go to see complementary and alternative medical providers like chiropractors or acupuncturists. A few make it to a hospital outpatient clinic. A few get home health care. A few go to an emergency department. Maybe 8 out of that 1,000 end up being hospitalized, and less than 1 out of those 1,000 end up being hospitalized in an academic medical center. And yet, that's where most of the research has been done, is on that less than 1% of patients that make it into an academic medical center, as opposed to the hundreds that are out here actually seeking care from us in primary care. So this is just an illustration. This is our Scappoose Clinic, part of the family medicine department at OHSU, out in Scappoose, which is a small community north of Portland. And this is OHSU. I think this is the dental school right down here. And you can see the estimate would be that there are going to be about 113 patients treated out here in primary care for every one that ends up at the academic medical center. Very different ecology, if you will. So what's the need for practice-based research? Why do we need this? Part of the problem is this, I believe. We wrote this article many years ago about diagnostic testing for low back pain, which happens to be a particular research interest of mine. And what we discovered was that the diagnostic evaluation that went on for a patient with back pain depended very much on what kind of practitioner they saw and what individual they saw. So it was clear that who you see is what you get when you present to a clinician with back pain. There's not the kind of consistency that you would hope for among practitioners. We all do something a little different, and you would hope that if we're all practicing evidence-based medicine, that this would be much more consistent. A second problem is that we actually deliver a lot of care that's ineffective. How might that happen? Again, it happens in part because we're not practicing evidence-based principles. Here's one example. This is the example of arthroscopic knee surgery for osteoarthritis. So this is not the same as surgery for a torn meniscus or for a torn anterior cruciate ligament. This is just for osteoarthritis, where the idea was we could shave the rough cartilage, we could wash out the joint and remove inflammatory mediators, and that would improve the symptoms for a patient with osteoarthritis. The problem is that when this has actually been tested in a randomized trial, compared to a sham procedure that just put a little tiny incision on the skin and went through all the same rigmarole of fluoroscopy and so forth that looked like a real procedure was happening, it turned out that this was actually no more effective than a sham procedure that never even entered the knee joint. And there's been a subsequent randomized trial showing that this is actually no better than simply good rehab from a rehab physician, for example. And yet, we were paying roughly $3 billion a year for this type of surgery for a large number of years, and it's still fairly common practice. Another example from the medical world as opposed to the surgical world has to do with treatment of high blood pressure. This ALL-HAT trial is a lengthy acronym for words I don't remember actually, but was probably the largest randomized trial of drugs for treating hypertension that's ever been conducted. And it showed that old-fashioned thiazide diuretics were actually a little more effective than several newer drugs at preventing the complications of hypertension. And yet, as this graph suggests, sales of thiazides had been decreasing steadily over the past few decades in favor of these newer drugs that cost basically 15 times as much, and many of which were actually not as effective at preventing complications of hypertension. One cardiologist estimated that had we been using diuretics all those years at a higher level, we might have saved 70,000 heart attacks a year and saved roughly $1 billion a year. So we're out there delivering things that are not optimal. And in fact, if you look overall, there are a variety of examples of effective care, things that we actually know work, but that we don't deliver. So on the one hand, we deliver things that don't work. On the other hand, we're not delivering the things that do work in a consistent fashion. These are just a few examples from a study that was done by the Rand Corporation in 2003. They concluded that overall, Americans get slightly more than half of the recommended care that they should be getting, and at least 11% received potentially harmful care. Some examples of under delivery were in the care of diabetics, where it's recommended that they get a hemoglobin A1C to assess blood sugar control at least twice a year, and yet at least a quarter of diabetics, or only a quarter of diabetics, were actually getting that level of surveillance. Among patients with a heart attack, nearly all should be receiving beta blockers following the heart attack, and nearly all should be receiving aspirin, and yet at the time, less than half were getting beta blockers, and slightly more than half were getting their aspirin. Colon cancer screening, again, recommended uniformly now for people over age 50. At the time of this study, less than half, considerably less than half, were actually getting that colon cancer screening. So there's some failures to deliver the things that actually do work. How would we do better at delivering that effective care? There are a number of approaches, of course, and this is just a sort of a high-level list, but certainly greater access to care might make a difference. We know that there's a substantial number of uninsured patients, people, I should say, who can't get access to the care they need. Convenience is a big issue in medical care service these days. Communication between doctor and patient, certainly, but also between providers is often a downfall. And simply reducing errors that we make, all of these things would go a long way towards more effectively delivering the care that we know matters. And in fact, Steve Wolf, who's in Virginia, has done some calculations that actually suggest that if we were doing these things, if we were delivering effective care more effectively, with higher fidelity, that we probably would be saving more lives than most of the new discoveries that come along in medical care. So at least in the short run, there's a huge gain from improving the quality of care. And then I alluded to the problem of sort of Ivory Tower guidelines, and I wanted to show you a couple of examples of those in the medical world. One example is a study that looked at all of the recommendations that we primary care docs get for doing preventive care. So this had to do with immunizations, screenings, counseling about lifestyle, and so forth. And the estimate was that if we actually followed all of those guidelines, that it would take up roughly the entire day. There would be no time for addressing patient complaints, no time for treating disease, no time for making diagnoses. We would spend the entire 8-hour day just doing preventive care. Obviously not a practical set of guidelines. There's been a set of guidelines developed for who should get imaging studies for low back pain. And the idea was, we're doing too many, we need to create guidelines that would be more selective. So people have written selective guidelines, but there have been a couple of studies now that show that if we were actually slavishly following those guidelines, it would increase the number of spine images that are being done rather than decrease them, because primary care docs are already pretty selective out there, something that seems to have gone over the heads of academics. Unstable angina guidelines, developed again by mostly a group of cardiologists, mostly academicians. Turns out that set of unstable angina guidelines actually doesn't apply to about 94% of patients who come to an emergency room with unstable angina. The reason is because of exclusions and contingencies within that guideline. So in fact, it's been shown that following the guideline wouldn't decrease the number of unnecessary hospitalizations and actually would increase demand for intensive care units, which was the opposite of what was intended by the guideline. Okay, so let me talk a little bit about a few examples from medicine of practice-based research that's been influential. Here's an example that deals with treatment effectiveness. Seems like a straightforward, obvious problem, and that is advising people who may be drinking too heavily. What you see in academic medical centers, of course, is mostly the consequences of end-stage liver disease in people who have been alcoholics and are in real serious trouble. In primary care, we're concerned about identifying people who might be at risk and trying to prevent that from happening. So again, different set of questions and different population. So this was a study that was a randomized trial from 17 Wisconsin practices that are part of the WREN network, the Wisconsin Research Network. It involved 64 physicians. They screened some 18,000 patients for problem drinking. Identified 774 for whom there might be some issue, some concern, and they were randomized to an intervention that involved just a couple of 10-minute counseling sessions with a scripted workbook or usual care, and they were followed out to a year. That may seem like a silly intervention or a trivial intervention, and yet nobody had actually tested it to see if such brief intervention would make any difference in an important lifestyle problem. It turned out that at the one-year follow-up, the result was that it appeared that this intervention actually did decrease the overall use of alcohol in the previous 7 days, had decreased the number of binge drinking episodes, had decreased the number of hospital days that these people spent. And this really was the first direct evidence that this sort of brief counseling could make a difference, and it really contributed to a current initiative that's going on right now, sponsored by a federal agency, which is called Screening, Brief Intervention, and Referral for Therapy, an approach to patients who have problem drinking or drug use, and this is now a nationwide initiative. Second example, this one sort of looking at the safety of doing less, if you will. What would happen if we didn't do certain things, that it became conventional care? This has to do with antibiotics for children with otitis media. It was clear at the time these studies were done that antibiotic resistance was already a problem. and accounted for increasing morbidity and mortality and cost in the U.S., otitis media was in fact the most frequent cause for prescribing antibiotics in this country. And there was fairly weak evidence at that point that routine use of antibiotics for otitis media actually decreased the duration of the illness or the severity of the illness or the complications of the illness. And so an international group of PBRNs actually started collecting data on the effectiveness of managing otitis media without antibiotics. And what they found was that in the Netherlands and Iceland in particular, clinicians were far less likely to prescribe antibiotics for otitis media. And in fact, they had lower rates of antibiotic resistance and seemingly equivalent outcomes that were no worse than they were in countries that used antibiotics more heavily, like the United States. This is a part of the evidence that led to a set of guidelines in 2004 that did recommend observation for selected patients and also recommended the use of more narrow spectrum antibiotics as opposed to the broad spectrum drugs that were being more widely used. Now, if you challenge me and ask, well, what effect did that guideline have? I have to tell you that the impact of the guideline has not been what you would hope for. Studies a few years after the guideline was issued suggested that, in fact, practices hadn't changed that much, and if anything, people were prescribing more broad spectrum antibiotics. We could speculate about why that is, but in any event, I think this is important because it led to an effort to change practice, and that effort is still underway. Another issue that comes up, certainly in medical PBRNs, is just identifying safety problems. Again, most of the research on safety issues has come from hospitals. Only a little has come from ambulatory care. And this is information that came from multiple U.S. Family medicine practice networks, just trying to identify the most common types of errors that occurred in practice. And there are things that might not surprise you. Errors in medication prescribing, errors in getting the right lab test for the right patient at the right time, filing system errors. Hopefully that will improve with electronic medical records. Medical dispensing errors, patients getting the wrong dose or the wrong drug after the prescription's been written, errors responding to abnormal lab results, often doctor not responding or patient not being informed about abnormal lab results. So kinds of things that perhaps are predictable, but knowing exactly what they are and how common they are helps us to figure out how we might try to intervene and improve practice along those lines. Another style of research hasn't had to do with intervention so much as trying to characterize a spectrum of disease or the natural history of disease. And this is an example of a study that really tried to look at the spectrum of conditions. Most of the studies on chest pain, for example, as a presenting complaint, had come from hospitals and emergency rooms, where, as you might imagine, there's a high prevalence of coronary disease, mostly heart disease. It's an area that makes doctors nervous. We always get nervous about the possibility of heart disease because it's obviously got important survival implications, results in a lot of diagnostic testing, results in a lot of utilization of services that often turn out not to be necessary. So these investigators at a Michigan research network asked, well, what really is the prevalence of diagnoses after people finish working up the chest pain in primary care, in practice-based practice? And the answer was it's mostly things like esophagitis, costochondritis, pain at the costosternal junctions, stable angina, musculoskeletal pain, a big part of it, and unstable angina, a very small fraction. So unlike what we saw in most academic medical centers, what people were seeing as a cause of chest pain in practice was only occasionally cardiac in origin. And this is a study that looked at the natural history of a condition, in this case, the onset of puberty in young girls. Seems like we ought to know what the natural history is, and yet I think probably prompted by some observations that didn't match what the textbooks said, a set of investigators undertook a study of the age of onset of pubertal characteristics in young girls, so breast development, pubic hair development, so forth. And this was undertaken in a large number of pediatric practices where they wanted to accumulate a large number of generally healthy young girls. Something you don't see at academic medical centers is generally healthy young girls. So there were 225 clinicians involved in this pediatric PBRN. They evaluated 17,000 girls. And what they found was that by the age of 7, for example, 27% of African American girls actually had some signs of pubertal development, and 7% of white girls did. This was considerably earlier than what was in the standard textbooks, and suggested some important racial differences. So in fact, this actually led the Pediatric Endocrine Society to revise their recommendations for the timing of referral for young girls for evaluation of precocious puberty. Another line of research that's been, I think, increasingly visible in recent years has been addressing problems of racial disparities in care and trying to understand why those disparities occur. And this was a study that was undertaken at Ohio practice-based research network. They realized that minorities received less preventive care. There was plenty of documentation that that was true. And they wanted to understand more about why they got less preventive care. So they did this study with 138 docs, 4,000 patients in Ohio, used direct observation of doctor-patient interactions, exit interviews with the patients, and medical record reviews. And they studied the screening and the counseling and the immunization recommendations from the U.S. Preventive Services Task Force, which are a set of pretty well documented and really rigorous preventive service guidelines. And what they found was that in these practices, there weren't any important racial differences in preventive care. And that suggested to them that, in fact, black patients who had access to primary care, the people who actually made it to the doctor, were likely to get appropriate preventive services, and that there didn't seem to be evidence in this case of clinician bias. The problem probably occurs at the level of access and patients actually making it into those practices, sort of suggesting a completely different point of intervention than you might think if the problem seemed to be occurring after they sought medical care. And then certainly quality improvement is an ongoing theme in practice-based research. And this is just one example in which the investigators said, okay, every practice is likely to need different strategies for improving preventive care. Let's assign somebody to actually study a practice and try to understand what might get in the way of delivering effective care and recommend tailored interventions to try to suit that practice. So they undertook a group randomized trial with 77 family practices in Ohio in which entire practices were randomized to an intervention or not. The intervention was just a one-day practice assessment by a research nurse who then tried to come up with some suggestions using tailored approaches to try to increase the recommended counseling and screening and immunization that went on in those practices. And the result actually was a significant increase in the counseling and screening. Immunization practices didn't change, but the counseling and screening did improve, and those improvements lasted at least up to 2 years in a subsequent study that evaluated what was going on sometime later. And this is just a list of the kinds of tools and approaches that they use. These are really low-tech kinds of things. Patient intake forms, Post-it notes, flow sheets, stickers that went on the chart, posters that patients could see, outreach calls, and the like. There were also some interventions that really involved more practice organization. And again, by tailoring these to the individual practice, they were able to demonstrate some important improvements. So, what about future possibilities? One possibility certainly is doing randomized trials, and I've heard Tim DeRuin say that you're already doing a lot of randomized trials. So again, I'm bringing coals to Newcastle here. What's happening, I think, right now is there's a lot of discussion about comparative effectiveness research in the medical world, which is sort of a new approach to clinical trials. This is the traditional design of a clinical trial. It would be some treatment being delivered by the pioneering experts who developed that treatment. It would be done with placebo controls. It would be done in some highly selected population that typically would be a fairly young population because you don't want them taking a lot of other medications for other problems, for example. You don't want them to have other clinical issues going on. So young, otherwise healthy population with a single problem, ideally, and often looking at some surrogate outcome, a laboratory test, a cholesterol value, a blood pressure value, something like that. But as these two homeless guys suggest, it looks like the paradigm is shifting. Good news, I think, in large measure. So the new paradigm of comparative effectiveness research is one that's really well-suited to practice-based research designs. We're asking not for treatment by the pioneering experts, but by average docs in average practice. We're looking for comparisons not to placebo controls, but to competing treatments. Let's face it, we've got treatments out there for nearly everything right now, and we don't really care if a new treatment is better than a placebo. We care if it's better than what we're already doing. And there's very little research, typically, that directly compares treatments head-to-head. Instead of these highly selected populations, what about treating the real populations that we actually see in practice, who typically are going to be older, they have other comorbid medical problems, they may be taking a host of medications for other things? That's actually the population that's going to be getting this treatment if it becomes widespread. Why not actually study that in the course of the clinical trials to understand what the implications are in that wider population? And why not study patient-relevant outcomes? So instead of a laboratory test, let's study something like survival or quality of life, the things that arguably are the most important for most patients. Oops. Doesn't want to stay on that previous slide. The previous slide has to do with strategies for implementing changes, and it really sort of reiterates this theme that there may be a variety of approaches that we're not using now. Case management services or strategies, team care approaches, electronic decision support strategies, and so forth. And I would argue that when these things are tested in a whole network like yours, we've basically shown the feasibility of those approaches. We've shown both the feasibility and the effectiveness, and there's really not much question that it can be done after it's been demonstrated in practices like yours. Now, I wanted to just elaborate on two of the points that were on the invisible slide there, one of which has to do with electronic decision support. This is a strategy that's gaining more traction now in medical practice, especially in large practices like Kaiser or Group Health here in Seattle. And here are two examples of some nice research that's looking at electronic decision support. These both came from Kaiser, actually, in Oregon. One was a study of drug interactions with warfarin, blood thinner drug that's commonly prescribed for a number of conditions, but has a whole host of drug interactions. And at Kaiser Northwest, they actually implemented an electronic reminder system to remind doctors of some of the most important drug interactions. And they were able to demonstrate a 15% reduction in co-prescriptions of those drugs that had important interactions with the warfarin. In another example, they were concerned that women who had fractures, older women who developed fractures, and often proved to have osteoporosis, weren't getting treated for osteoporosis or weren't getting evaluated even for osteoporosis, in part because the primary care doc might not be aware of what happened in the emergency room. Patient comes in with a fracture, gets treated in the emergency room, doesn't see the patient until perhaps months later. And so they developed a strategy whereby docs would be notified anytime there was an X-ray performed on a patient that showed a fracture, and a little reminder about bone mineral testing and osteoporosis therapy for women who were sustaining fractures that they might not otherwise have attended to or thought about osteoporosis screening. And I thought I'd show you an example, too, of the notion that's also gaining traction in the medical world of shared decision-making, patient-shared decision-making, which is a notion that a lot of what we do is elective. And I dare say that a lot of what goes on in dentistry is elective procedures, where there may often be multiple options that a patient faces. And patients ought to be involved in those decisions. It's especially important in medical care, and there are a whole host of elective procedures that we do where reasonable people might actually choose different things, and yet we often present them with my recommendation and just my recommendation, rather than laying out the options. And I'll walk you through an example here that perhaps is too lengthy of some work that we did with back surgery, developing an interactive video program to try to inform patients what their options were regarding back surgery. And the motivation behind this was that we've done studies and others have done studies that show wide geographic variations in rates of spine surgery. There are 5-fold differences between rates of surgery in New York State and Oregon, for example, with Oregon doing about 5 times more back surgery than New York. And that's hard to explain on the basis of any epidemiologic prevalence information. We also knew that lumbar spine surgery is usually elective. It's usually not something that prevents paralysis. It's something that is done for pain relief, and it's usually a purely elective procedure. Patients might weigh the risks and benefits differently, and their preferences ought to play a major role in the decision about this. And furthermore, we argued that physicians often can't remember all of the relevant information that a patient might want according to the patient's age and the diagnosis. And even if they could remember all of that information, they often don't have the time to go through it in great detail. And wouldn't it be nice if they had an aid for that? So we developed an interactive video program. Unfortunately, because I got here late this morning, I didn't have a chance to link this to the video program, but I was going to show you about a 30-second excerpt from this program that was based on an interactive video disc, actually, a sort of old technology. And what you would have seen were, first of all, an introduction that showed some animation, showed what a herniated disc looks like, shows the vertebrae in the spine and so forth. Then a couple of actual patients sort of giving their testimonials, one of whom says, I had disc removed and it was the most fantastic thing that ever happened. I honestly can't remember that I even had the surgery unless I really think about it. I'm doing great. Everything went perfectly. And then the next guy who says, I thought this was going to go smooth as silk and it was just going to be like putting on a cast and then you take it off and everything's better. Didn't work that way, he said. Instead, I still had pain afterwards, had to go through a lot of rehab, took months and months, and it just wasn't what I was expecting. So the idea is to present both good and bad outcomes so that patients can get some vicarious sense of that. And then it would show you some detailed tables of what the outcomes would be that you might expect from these things with actual probabilities as best as we could estimate them from existing literature and also from large epidemiologic databases. And having produced this decision aid for patients with back pain, we tested it in a randomized trial where we compared this interactive video program with just a written patient education brochure. What we found was that for patients with a herniated disc, people who watched this video program actually ended up having about 30% less surgery. And yet, when we followed them up at a year to test their pain level, functional recovery, return to work, disability compensation applications, the results were identical, even though this group ended up having 30% less surgery. Among patients with spinal stenosis, the story was a little different. Among those who saw the video program, more people chose surgery. And we think that's because of the very different probabilities and very different information that we were able to present for spinal stenosis as opposed to herniated discs. We found that patients preferred the video to the written materials. We actually did some formal knowledge testing and showed that people learned more from the interactive video program. They felt better informed. And we argue that this might really be a valuable adjunct to the process of eliciting informed consent, because patients really are better informed once they've gone through a process like this. And the cost impact would actually depend very much on what the baseline surgery rates were in a community and what the mix of diagnoses might be. There have been other trials of decision aids like ours that actually suggest that in general, patients who see these decision aids choose less aggressive therapy than they might have otherwise. So women facing hysterectomy for excessive bleeding actually chose less surgery. Men who were given accurate information about PSA screening, that's prostate-specific antigen screening, actually chose less screening once they saw the probabilities and the potential risks. Patients with stable angina chose less bypass surgery or angioplasty after seeing the actual benefits and risks laid out in front of them. So there seems to be a consistent theme here. In fact, there are now some 80 or so randomized trials of decision aids like this, and they generally do suggest that patients choose less invasive therapy by at least a few percent. So quick summary here of what I think are some useful contributions from practice-based research. Measuring treatment outcomes in routine care, that's fairly obvious. Comparative effectiveness studies, they've been done and I think will be done more in the future because more funding is going to come that way. Studying natural history of disease and the spectrum of disease is very useful. Strategies for patient or public education and self-management, that's where this idea of shared decision-making comes in. Helping doctors and policymakers to be more discriminating in their use of new technology, and testing quality improvement interventions. These are all things that have been done in practice-based research and I think have made important impacts. So my quick overall summary of the role of practice-based research is to remember that evidence-based practice is probably very important, and the delivery of that evidence-based care is not as simple as just writing guidelines. That's clearly not enough. We need higher fidelity in delivering effective care, which may in fact have greater impact on population health than most of the new discoveries we make in the laboratory. Practice-based research, I think, really is the missing link between academic clinical trials and high-quality practice, and it's the right laboratory for testing practice innovations. And in turn, your practices can make major contributions to the entire research agenda and the quality of research. So I think a rallying cry for practice-based research might be this comment from Mark Twain, who said, "Supposing is good, but finding out is better." Thanks very much. Got a few minutes for questions, have we? Yeah. Questions or comments or arguments?
Any questions?
Yes.
Around the room too, Tim.
Okay, here we go. This pertains to the patient education video disc. Just curious, how did you interject that into the process of relating to the patient during the appointment and so forth?
Yeah. The question is how did we actually use that decision aid and weave it into actual practice? That's the biggest challenge that faces this field of shared decision-making right now is when and where to use this. I'll tell you what we did in our clinical trial. One of the study sites was at Group Health here in Seattle, and the surgeons at Group Health actually told us, we would like you to have patients see this before they get to us. So when you get a referral from the primary care docs, we'd like you to show it to the patient between the time of their referral and the time we actually see them. And we were able to, with the assistance of the health plan, intercept those referrals as they were made. try to extract from the referral as much information as we could about the patient and what condition they likely had. And we contacted those patients by phone, went through the consent process, and showed them the video program before they actually made their appointment with the orthopedic surgeon. And I actually think that approach has a lot of promise if the logistics could be worked out in routine practice. And I think many people believe that's the ideal spot. The other study site in that study was actually the University of Iowa, where it was a spine clinic that was the study site. And at that site, patients were making an initial visit to the spine surgeon after being referred. And it was after that first visit that we tried to get them to see the video disc, the video program. Again, we had the advantage of having research assistants and people who could do that step, actually go through the process of consenting patients and delivering the video program in the office. So we had resources that might not exist in a routine practice, and that's one of the challenges that I think faces this field. But you could imagine that if in fact there were some reimbursement for doing the shared decision-making process, it might be possible to create the resources that would be necessary in routine care. But people are still struggling with that. How does this fit into practice? Yeah.
So I'm curious if there's what your feelings are in terms of providing patient information. Is there ever a way to do it in a completely unbiased way? For example, in that video, has anyone studied, for example, what happens if you reverse the order of the information that's presented, put the bad thing first and the good thing second?
Yeah.
Does that impact the decision making?
Yeah.
Because we know people generally make decisions emotionally, and often what they do last is the most important part. So I don't know if we can ever develop, whether it be from a personal standpoint or a video, something that's electronic,
Yeah.
in a way that's totally unbiased. You can read body language, you can read all kinds of other things.
Yeah.
I think it's a big challenge.
Yeah, your point's very well taken. In fact, there's an international society for decision-making of this sort that has tried to come up with criteria for evaluating decision aids that aim at trying to ensure higher levels of objectivity because you're quite right. If you put this in the hands of a device maker or a drug company, it's easy to imagine even subtle things that would steer a patient one way or another intentionally. And certainly those of us who don't intend to steer patients may do so unintentionally for just the kinds of reasons that you're describing. And so there's a lot of thought being given to how you might design these programs in a way that's completely unbiased. Some people argue that we shouldn't show patient testimonials at all because they're so biasing, because people react so emotionally to those patients. I either identify with them or I don't identify with them, and so forth. The other school of thought, the opposing school of thought is, well, gosh, information is just so bland that most patients don't pay much attention, they don't remember numbers, and doesn't have much salience for them, and actually seeing a good and a bad result may actually be more helpful to them than all of the numbers that we provide. So there's still arguments going on about those things. To answer your question, there are some people trying to test the kinds of things that you just asked about. Does it matter what order these things are presented in? Does it matter if we show patient testimonials or not? To try to evaluate the balance of these programs, what we've typically done is to show them to groups of patients and to groups of physicians and ask, how do you think this is in terms of balance? Is it too far to one side or too far to the other? And in general, happily, the decision aids that we made for back surgery and decision aids that are being made by a foundation that I work with generally look pretty good. You see typically a nice bell-shaped curve with most people saying it's just right. It's right in the middle. It's fair. It's well balanced. A few people on each extreme, but in general, people find these things to be well balanced. In the absence of some more objective measure, that's probably the best we can do right now. Is to just try to test experts and lay people for their sense of how balanced the material is. But it's an ongoing area for study. That's for sure. Yes.
The individual genetic testing, influencing the treatment of management of disease for persons.
Individual genetic testing for disease management. Yeah, it's gradually becoming, or maybe rapidly becoming, a reality, I think, in cancer care, where people are starting to talk seriously now about choosing chemotherapy regimens based at least in part on actual genomic analysis of an individual patient. And there certainly are examples in cardiovascular medicine and elsewhere of gene variants that affect patients' responses to drugs, for example, and where we have to tailor things. So I think the genomic revolution is going to affect practice in some ways. So far, I think that impact has been fairly small. There's actually some concern about the way it is being used in cancer today and whether, in fact, people are inferring too much from the genetic information, the gene sequencing information that's sometimes done. But there's little doubt in my mind that more genetic testing is going to be in all of our futures. And again, I think practice-based networks are a place where it'd be nice to see what the actual impacts of these things are in routine practice, because I can almost guarantee that the research that's done in academic medical centers is going to be done in a rarefied group of patients that may or may not really be representative of what the average person out there in the world looks like. Other thoughts?
Can I just add one comment to that? One of the issues that you may have heard earlier, that we had proposed doing a study using genetic testing looking at caries risk. And one of the concerns at the time from NIDCR was getting consent for genetic testing through practicing dentists and issues related to that, and what they were getting consent for and what might be done in the future, whether you're accurately getting consent for what might be done with those tests. So it's a tricky issue to do in practice like this.
A whole set of thorny questions about the consent issues that everybody is wrestling with, and you may be familiar with the story of the Havasupai tribe in Southwest.
Right, exactly.
That had blood drawn for some genetic tests. They understood that, but then it was used for things that they didn't realize it was going to be used for, and took issue with that use of the of the samples that had been collected. So I think those are all issues we're going to be facing over and over again, I suspect.
I think we need to move to the next presentation, or we'll get too far behind in a very packed agenda. So, Rick, thanks again for your perspectives from medicine.